Welcome to the AUA News Inside Track podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
Hello, I'm Dr. Amanda North. I'm the Chief of Pediatric Urology at Montefiore Medical Center in the Bronx. And I'm also the soon-to-be outgoing chair of the AUA Data Committee. I've served on the Data Committee for 8 years now, and my primary interest has been in the AUA annual census. And so today we're going to have a conversation about some of the census numbers regarding fellowship training. I'm really happy to introduce my co-host, Dr. Susan McDonald, who can go ahead and introduce herself.
Co-host and former resident, Dr. North, who was my mentor in residency at Montefiore. Now I am program director at Penn State. I do male reconstruction and sexual medicine and take a significant interest in surgical education.
Excellent, Susan. It's such a privilege to be able to do this podcast with you.
That's fun.
Thank you. So we wanted to talk today about fellowship training in urology and some of the interesting statistics surrounding fellowship training. So using AUA Census data, I went back to our original AUA Census, which was back in 2014. And then I pulled the numbers from the most recently published census, which was only published a couple of weeks ago, which is the 2024 census. And just for context, back in 2014, 7.7% of practicing urologists were women. We're now up to 12.1% of practicing urologists being women. And interestingly, 21.5% of urologists under the age of 45 are women. So we expect the percentage of women to increase as some of the older urologists retire. What's really interesting, though, is that young urologists seem to be pursuing fellowship training at a much higher rate than older urologists did back in the day. And so part of the conversation we want to have today is about why there are these differences in fellowship training between the younger urologists. Interestingly, in 2024, young men under the age of 45 did fellowship training as frequently as women did, which is a new change in our census data. But both are doing fellowship training at almost 2/3 of urologists under 45 are doing fellowship training. And Dr. McDonald, I'm really interested to hear what you have to say about that as an expert on generational differences in practice.
Yeah, I did just talk about that at the Society of Academic Urology. So I think one thing that is driving this is actually the patients. So there is, there's Dr. Google, and everyone wants an expert beyond what they can find out for themselves on, WebMD. So I think that there's some pressure from the patient population to really have expertise behind your name and the credentials so that you can, flash that when you give an explanation or recommend a surgery. I know that as women, we also consider how much female urology we'll be doing in practice. So although male reconstruction was always what I was destined to do, I know you and I have had some anecdotal conversations, and it's been featured in some Facebook groups and WhatsApp groups that we're a part of, about how women find that female patients are shunted to them because of their gender. So I'd like to reference an excellent paper in 2017 in the journal in Urology, the Gold Journal. The senior author is Kathleen Huang, and they surveyed ABU case logs and looked at a roughly 4,000 urologists, 300 of which were women, and found that women do female urology type cases based on CPT codes at double the rate of male urologists. And that trend was agnostic to geography or even stage of career. So it was true at recertification and second recertification as well. And that's called What's Gender Got to Do with It, which is such a great article title.
That's amazing. There was also an article in the Journal of General Internal Medicine, so not something most urologists would see, that found that women doctors were expected to see patients that were considered frustrating or difficult for psychosocial reasons, that those patients greatly preferred women doctors over men because women doctors are perceived as being more empathetic. But what that did was it increased burnout among women doctors because they were seeing patients who were more time consuming, more frustrating, but didn't reimburse any better or sometimes even worse. And I think there is, at least theoretically in urology, the same concern that women urologists are being expected to see the patients that nobody else wants to see, who may not be surgical candidates. And as surgeons, of course, our RVU productivity is much higher when we're doing surgery than when we're spending a lot of time counseling in the office. So another reason for women who don't want to be mired in patients that are non-surgical to do fellowship training.
Yeah, I know AUA census data would suggest that men and women self-report the same number of work hours, but I know outside of our field, there is data to support that women spend longer in visit times, which again goes back to your like, I see chronic pain patients, and those patients take me a considerable amount of time as compared to, say, my reconstruction patients. Um, and also, women tend to spend more time in the EMR. So, I don't know if fellowship necessarily abates all of those things. I think some of those are, the people pleasing aspect of women and gender roles in society. But fellowship certainly may give you the privilege of doing some higher complexity surgeries.
Absolutely. And the census data echoes that. So we know from census data that women urologists consistently report spending more time per patient than men and tend to see fewer patients per week than their male colleagues. And so that's also true in our specialty. We also know that women are much more likely to go into academic practice compared to men. So 40% of women end up in academics, well, less than a third of men do. And so I wonder if this desire to be in academic medicine drives some of the fellowship decisions. What do you think?
I think that would be true with the earlier data when you referenced, I think 2014, definitely. Now that things are equaling out, I wonder if it's more driven by, um, if we go to work hours and we talk about the impact where I feel like also the breadth of urology is expanding, like we're doing more and more things and it's different skill sets and it's hard to maintain all those skill sets. So, with HOLEP and robot and endo and recon and ERPs and pediatric, like there's just so many different facets and skills now, that maybe fellowship training is just a way to hone your expertise so that you don't have to maintain and be kind of a jack of all trades, master of none.
That's a really good point. We recently had, to name drop again, Dr. Kate Kraft from Michigan came as a visiting professor and gave what our residents considered to be one of the best lectures they've heard from a visiting professor. So thank you, Dr. Kraft. And she spoke about some of these challenges about residents not feeling ready for practice when they finish. And I think, back in the day when I trained and we didn't really follow work hour regulations, I trained in New York where we were supposed to, but I can assure you we did not. Um, our case logs were much wider in terms of the number of cases we did, but also, the first robot at Montefiore was purchased the summer after I graduated residency. So we were doing tons and tons of open surgery, which our residents aren't necessarily getting that same experience that we had. Um, and I think that the feeling that we were competent to go into practice surgically was greater, back I graduated residency in, let's see, 2005. And so, I wonder if there isn't a little bit of insecurity over the training that people are getting now.
Yeah, I think the perk is versatility. Like it's nice to know if we take BPH, for instance, it's nice to know green light, TERP, Urolift, aqua ablation, resume, etc. But if in a residency, what's really happening, each faculty member picks one modality of treating BPH, but then the residents have to split their BPH case volume between all these different modalities. They're not going to be as confident in any one particular surgical technique.
That's a good point. I do also wonder, there's been a change in how people practice after residency. Again, back in the day, people could hang up a little shingle outside of their house, exaggerating a little bit, of course, and open their own practice and be a practice owner. And now we're seeing a huge shift towards the employed model, where the minority of urologists are now in private practice. And even in my area, one of the largest urology practice groups just recently was purchased by private equity, where they went from being practice owners and now they are, again, employees. And I wonder if people don't think that doing a fellowship will make them more hireable, now that fewer and fewer people are becoming practice owners.
I'll play devil's advocate and dissent there and say, I get what you're getting at, but um, as someone who is the program director and I get ad nauseum emails, I am well aware of the doctor shortage and the number of people looking for urologists. And my current graduating chiefs are not going into fellowships, and they are hot ticket items, right? So I think that the push towards I think it would be the opposite way, where private equity, they're looking for bankability and someone to see their patients, fellowship trained or not. Whereas actually, if it was an autonomous practice, that's where you might actually want like one or two people in the group to be fellowship trained to have that expertise.
That's a good point. And also, I know our friends who run the Thriving Urology Practice Facebook group talk a lot about how, from a profitability point of view, doing office-based procedures can actually be more profitable than going to the operating room. I've heard it be said, and I'm a pediatric urologist and don't do office-based procedures at all, but I've heard it be said that, the operating room is an expensive habit if your real goal is to make money. And so I guess from a private equity point of view, maybe actually having people who do more office-based procedures and fewer big operations might actually be beneficial.
That's like a key point why I'm in academia along with teaching. I love to operate.
Exactly. And for us as pediatric urologists, the ability to do office-based procedures is a little bit less, I think, than for our adult colleagues too. So good point, good point. Um, Interesting. So I find the gender disparity in fellowship training really interesting, because when we look at older urologists, men are very unlikely to have done fellowship. So in urologists over the age of 45, only about a third of men have done fellowships, where again, still almost two-thirds of women have. Do you think that's because women felt like they needed to do fellowships back when they were the minority, even more of a minority, I guess, of urologists in order to market themselves?
Probably. I feel like I was at a transitional point between when um women had to take a lot of flack and deal with a lot, and we started talking about gender equity in my early years in practice. And I still felt some of what the older generation back in your day would have felt, but also some of the new wave where, having a child in practice was not unheard of. Um, so I think I'm a middle ground, and yeah, I think having fellowship credentials behind your name cements you as someone, and having done, a 6-year residency as opposed to 5-year, just cements you as someone who's in it to win it, working hard, has specialty knowledge and skillful operating. Um, it's not to say without fellowship you couldn't be savvy at branding or prove yourself, but I think people do often pigeonhole women.
Yeah, that's true. I guess for me, it's different because I went to med school to be a pediatrician. So it wasn't shocking once I found my way to urology that I would choose to be a pediatric urologist. Taking care of children was always part of my plan. So I'm a little different because I didn't do fellowship for any of those reasons. I did it because I just wanted to take care of kids. Maybe that's why I have 3 children of my own. I don't know. But I do think for other people, there are a lot of complex reasons to do fellowship. And so, and I know for you, it was love of reconstructive urology.
Well, urethroplasties, essentially. But I think, we should talk about the reasons why people don't do fellowship. So when I have mentor conversations with my residents, a lot of people bring up the time. So having to move to one more location and take another year out. And some of these people have already started their families because in a positive way, we are making that more acceptable during training. So that's wonderful. But then they have to shift not only themselves, but their spouse and their children. And then also the money aspect. So people have done studies, and I don't remember the exact metric, but every year of training costs you some substantial amount of money. So those are detriments, but yet fellowship training is clearly increasing.
That's so true. I think specifically with pediatric urology, um, the last several residents I've had who were genuinely interested in peds decided at the last minute not to pursue it, in part because there's not currently a pediatric urology fellowship in New York. And so, for exactly the point you're saying, having to move your family, I mean, that when I did my fellowship, I had lived apart from my spouse for 2 years and I had kids already. So it was really challenging. I know the study you're referencing, I know Doug Huseman had done a study out of Mayo Clinic that showed a substantial cost per year of training. And that was part of the push when residencies moved from 6 years to 5, was that it was very expensive for the residents in terms of lost wages and increased debt on their student loans. And so I think that's a really important point too.
Yeah, I think we're getting at it's just multifactorial. There's a lot to digest here.
So I wonder going forward, as residents seem to be graduating feeling a little bit insecure about their surgical skills and ability to go straight into practice, if we're going to continue to see this trend of almost 2/3 of residents doing fellowship, or if as we move forward, the costs of doing extra time of training will outweigh any perceived benefits. So I know we're not future tellers, but if you were going to guess, what would be your impression as a program director?
I think the push towards fellowship will continue. The only way, and it's a very limited capacity that you would get around that, is if a resident knew they were joining a practice with an established mentor, someone who was mid-career or up, who would take them under their wing like an apprentice model and get them through the choppy younger years. Otherwise, when you do a fellowship, not only do you get that fellowship training, but you get the built-in mentor, the fellowship director that essentially guides you into early practice.
That's true. A few of our residents who went into private practice straight out of training joined academic departments as generalists. And that allowed them to have that kind of mentorship and support in the beginning of their practice years. And so it's an interesting model where these residents are choosing to practice in academic settings for the support systems that involves, but not do fellowship. And I think that that's probably a really good compromise.
Yeah. So there you go. PSA to future graduating residents, as long as you have a good mentor, you can get by. A mentor like Dr. North, to plug her again.
Thank you so much. Is there anything else we should mention in terms of fellowship training?
I can't think of it. Go where your heart leads you. That's it.
Don't be afraid to go into practice straight from residency, but if there's something you feel really passionately about or something you want to explore further, fellowship can be a great way to do that. And if you're worried about being pigeonholed into doing things that you don't want to do, getting that fellowship training so you can, market yourself as an expert in stone disease or female urology or pediatrics is a really nice way to go. So I think you can't do wrong, whichever you choose.
Totally agree. Thanks, Dr. North. Great conversation.
Thank you, Dr. McDonald.
This has been an AUA News Inside Tract podcast. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.